ಶಂಕರ್ ಸರ್ ಅವ್ರ ಮೊದಲು ಜ್ಯೋತಿ ಮಾತಾಡಿಸಿದ್ಮೇಲೆ ಆಮೇಲೆ ನಿಮ್ಗೆ ಹೇಳ್ತೀನಿ ಸರ್.
ಆಯ್ತು 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 ಆಯ್ತು.
Hello, Dr. Shangram.
Yeah, we are starting, sir. 1 minute.
Okay.
Yeah, it's 7, sir. We'll start. A very good evening to one and all. I heartily welcome all the members of API, ICP, Karnataka, and other members of various organizations who have joined virtually from all over the country to attend this program of World Kidney Day. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus, RGHS and KVN University, Gulbarga. I also welcome our own committee members, Patron API, Dr. Maya, Dr. Suresh Sagara, Chairman, Dr. Vishwanath, Secretary, Dr. Ravikirti, Srinivas Murthy, Central Committee members of API. I welcome our today's chief guest, Professor Dr. Jyotirmay Paul, President National API from Kolkata, who was kind enough to accept the invitation and join. A great academician, researcher who has taken National API to an international level by doing great academic events, a great name in the API family in the country. I also welcome our today's speaker, Professor Manisha Sahai, Professor and HOD Department of Nephrology, Usmania Medical College, Hyderabad, a prestigious institution. She is a great academician, researcher with innumerable publications, both national and international. I welcome our today's moderator, Professor Dr. N.P. Singh, nephrologist, who has joined from USA, who was kind enough to accept the invitation and moderate that speaks his dedication and love to academics and teaching mainly the youngsters, a great name in nephrology in the country and Delhi. I welcome our panelist, Dr. Ashok Kriplani, a doyen in the field of nephrology from Mumbai, a great teacher par excellence who will be joining in spite of his busy schedule shortly. I also welcome our other panelist, Dr. Anupama, our own faculty nephrologist from Shimoga. I welcome our academic engine of WhatsApp University, so-called, the great Dr. N.K. Singh from Dhanbad, who needs no introduction as he is running CME India WhatsApp cases and other academics in the forum. Let us not waste time by reading the CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु.
We are virtually honoring all our faculties as well. Now I request our API President, Dr. Jyotirmay Paul, to say a few words as he has got programs others he has to attend. I will welcome his first. Dr. Jyotirmay Paul.
Thank you. Very good evening. Dr. P.S. Shankar, Emeritus Professor of Medicine, Dr. Shangram, Dr. Suresh, Dr. Muruganathan, Director PRF, Past President API, Dr. Ravikirti, Dr. Srinivas Murthy, Dr. and all my colleagues, students, juniors, and seniors. I welcome and congratulate API Karnataka branch because time to time I have observed they are conducting CMEs on the special days. These special days are basically to increase the awareness of a particular disease among the doctors and also among the people. Because for prevention of a disease, with cooperation from both the physicians' awareness for the actual modalities of treatment, for the better to cope with the better and advancement of the science related to that field of medicine, and also people's cooperation. So, all kidney day is very important because the kidney disease is now increasing, particularly in this part of the globe, because of the increased incidence of diabetes and hypertension And more than 50% disease in our own study, we have observed in West Bengal, 50% people not aware that they are having the hypertension. And among the 50%, another 25% not with the proper control hypertension. So diabetic and hypertension not only poorly controlled in our country, also awareness is poor. That is why the kidney disease is increasing. So I congratulate such type of scheme, what you have undertaken to educate the doctors with the advancement of science in this field of medicine. At the same time, I request Dr. Shangram, Dr. Ravigit, Dr. Suresh, leaders of API Karnataka, to undertake some of the awareness program of the people, common people in the village, how they can prevent hypertension, diabetes, metabolic disease, and so on the kidney disease. Thank you.
Yeah, thank you, sir, for sparing your valuable time. Now I request Dr. Muruganathan, sir, Director PRF, to say a few words for that.
Thank you, Dr. Sangram. I congratulate you for always observing the national days and creating an awareness among our physicians. And I thank all the participants, and my request to API Karnataka to form the PRF wing, because many states have already formed. So Suresh and other people said they will send the list. Kindly get the 50 signatures of your API members and send it to the head office, so that we will form the API PRF wing of Karnataka, which is very good. And as the president says, we always think about prevention. And one of the things is hypertension. You must control hypertension. You must control diabetes. I'm sure Manisha Sagai is going to talk about how to control or prevent kidney disease. Now, a lot of advancements have come. The cardiorenal syndrome itself is big. And now the metabolic syndrome also includes kidney problems. So kidney is a big organ now in all the complications, problems. So I think Manisha Sagai's talk is going to be very useful for everyone. And all the physicians should learn about the common problems and pathogenesis, how these things are developing through kidney. Thank you very much, Sangram. Over to you.
Thank you, sir. Thank you for sparing your valuable time. Now I request Dr. P.S. Shankar, sir, for your introductory remarks and address the gathering.
Dr. Jyotirmay Pal, Dr. Muruganathan, Dr. Maya, Dr. Suresh, faculty and office bearers of the API, both state and center, colleagues and friends. We have assembled here for the World Kidney Day, which is a global healthcare event celebrated on second Thursday in the month of March every year since 2006. The International Society of Nephrology and the International Federation of the Kidney Foundation, the World Kidney Alliance, have collaborated to create World Kidney Day. And this enables to bring together the patients suffering from kidney diseases and promote awareness of amazing kidneys by educating the people about the role in maintenance of the kidney health in our overall health and reducing the frequency of the kidney disease worldwide. After all, there are two good friends of the physician. One is the liver that detoxicates, and the other is the kidney, which eliminates. The theme for this year is Are Your Kidneys Okay? Detect early and protect the kidney health. And it raises awareness about the importance of the early detection and intervention in preventing kidney disease, to emphasize the life-changing impact of the early detection and intervention, and to highlight the importance of early detection and intervention for those who are at higher risk. Kidney disease, particularly chronic kidney disease, CKD, can go unnoticed until it reaches severe stages. Early diagnosis can significantly improve the outcome. In the background of diabetes, hypertension, or the family history of the kidney disease, the individual should get tested regularly. Living with a chronic illness such as kidney disease can take a toll on physical health of the individual, and it can radically change the ways people think and feel about themselves around the world. We need not give in to the circumstances, but to take the challenges that strike and live a meaningful, happy life. Chronic kidney disease is estimated to affect nearly 850 million people worldwide. The approximate prevalence of the chronic kidney disease in India is 800 per million people, while the incidence of end-stage renal disease 150 to 200 per million. Diabetic nephropathy is the most common cause in India, and it has been projected that CKD is to become the fifth leading cause of the years of life lost, highlighting the urgent need for global strategies to combat the kidney disease. Early detection programs for individuals at risk should be implemented globally to reduce the healthcare costs associated with kidney failure and improve the quality of life. CKD can develop at any age, and various risk factors can accelerate it. Detecting the kidney disease early is essential for preventing complications and improving the quality of life. Diabetes, hypertension, obesity, family history of the kidney disease form the major risk factors for the kidney disease, and proper checkup and treatment has to be undertaken. It is to be noted that people of South Asian geographic regions, that includes India, have a higher risk of contracting chronic kidney disease. In this background, the global call to emphasize early detection of the kidney disease to prevent the complications and ensure long-term kidney health has a great relevance. It has urged for the global awareness, proactive measures to safeguard the renal function. In India, the epidemic of chronic kidney disease has necessitated to bring about a greater awareness among the people due to increasing diabetes load, hypertension, and an aging population. The oncoming wave of CKD can be encountered only with awareness. Understanding can help in early detection of the kidney disease. There are some important chronic kidney disease preventive tips such as healthy, balanced diet, avoidance of sedentary lifestyle, check and manage the blood sugar levels, check and maintain the blood pressure levels, abstinence from tobacco consumption, adequate fluid intake, and avoid regular use of non-steroidal anti-inflammatory drugs. One has to adopt certain lifestyle changes for kidney wellness. It is necessary to undergo regular health checkup to monitor the kidney function and to detect the symptoms of the renal disease early on and for timely action and care. Avoidance of chronic stress to maintain proper blood pressure, which is the risk factor for the kidney disease, and adequate sleep. And World Kidney Day raises awareness of the kidney health and the kidney disease and encourages people to take action to prevent the kidney problem. In this background, the APA, under the guidance of Dr. Sangram, has organized the World Kidney Day, and nephrologists from different parts of the country are participating in this particular program. I wish the program all success. Thank you.
Thank you, sir, for your extensive overview of nephrology prevention. Now I request our chairman, Dr. Suresh Sagrat, to say a few words.
Thank you, Dr. Sangram sir, for organizing this World Kidney Day Zoom meeting. Because of your efforts, Karnataka API is being showcased at national level also. And aptly, you are organizing various programs on various days so that physicians are made to aware about these issues. Dr. Shankar has already highlighted about the importance of celebrating this day with focus on prevention, early detection, and therapeutic aspects of kidney disease. And we will hear more from our panelists and speakers. And I think we need to move behind hypertension and diabetes now, because what is the role of environment in these kidney diseases needs to be looked at. I think there will be a good discussion is going to happen on World Kidney Day. Thank you, sir, for organizing this program. Good luck and best wishes from API Karnataka.
Thank you, Dr. Suresh. Now I request our moderator, Dr. N.P. Singh, to take over since all the faculties have been introduced. Over to you, Dr. N.P. Singh, for your moderation.
Thank you, Dr. Sangaram, and it's my great pleasure and honor to be a part of this Karnataka API for organizing this World Kidney Day. Without any further ado, because we are already getting late, so I would request Professor Manisha Sahib. Professor Manisha is well-known personality, not only in internal medicine, but also nationally and internationally in nephrology. If I have to talk about, suffice it to say that she's very active in preventive strategies. She's very active in women in health, women in kidney, so and also spearheading a lot of preventive work for that. So welcome, Professor Manisha, and kindly start your talk, and then we'll have some. I'll request you to kindly stay back after your talk so that we can have some points on discussion and panel discussion. Right, over to you. And I welcome other speakers. I welcome Dr. Anuradha. She's here. I welcome Dr. N.K. Singh as well.
Is my screen visible, sir?
Yes, yes.
Yeah. You can go to
Yeah.
Great.
Thank you very much. It's indeed a proud privilege for me to be a speaker on this forum. API, I feel, is the mother body, and medicine is the mother of all specialities. And thank you really very much. So today I'll be talking about, as has been alluded to by Dr. Shankar, about the kidneys. Are your kidneys okay? That's the title of my talk. Now, why do we celebrate this World Kidney Day? You know that World Kidney Day is today, and has already been informed that we celebrate World Kidney Day on second Thursday of March every year. And why do we celebrate this World Kidney Day? Obviously, because the kidney awareness is very, very important. We know that all causes of kidney disease are becoming very common, be it acute kidney injury, nephrotic, nephritic, tubular disorders, renal vascular disease. The most important thing is, if we do not treat them, many of them may progress to chronic kidney disease. And this is what we are scared of. CKD, chronic kidney disease. Your kidney dysfunction persists for life. Why is it important? The percentages have been alluded to, but to make it more practical, 1 in 8 Indians, according to one study, have CKD, 17%. And diabetes, we know, affects around 17 to 20%. We are all aware of diabetes, at least little bit aware of diabetes. The public knows about diabetes, but CKD, it's almost equal to diabetes. And many people, unfortunately, are not aware of chronic kidney disease. Also, 2 lakh people in India develop end-stage kidney disease every year. That's more than population of many countries. And they need dialysis or a transplant. This is a huge economic burden, not only for the patient, but for the government, for our economy also. Transplants are available in India. We do around 15,000 transplants per year. Good number. We are second largest country in the world behind US. But again, look at the numbers required. 2 lakh transplants per year, and we are doing only 15,000. The remaining patients either go on dialysis, or if they don't have access, they simply die. Transplants, apart from being costly, the donors are also limited. So everybody does not get a transplant. Now, the good thing is we have strategies which can protect the kidney. But the most important thing is you can use these treatments if the CKD is diagnosed early. We cannot use these strategies if the patient comes to us in the last stage of kidney disease, when only we can do either dialysis or transplant. Now, who should employ these screening strategies for CKD? All of us are responsible. We are a population of 1.4 billion Indians with only 2,500 nephrologists, limited number. Patients reach the nephrologist late in the course of the illness. Early stages are seen by everybody, right from primary care to secondary care to tertiary care. So who should be doing the screening? All of us, but more emphasis on the general practitioners who see a huge load of patients. They do a commendable job. Physicians, everybody, be it any specialty, nephro, cardio, gynec, every healthcare professional should be equipped to screen for CKD. So everybody should know the basics, and this is very important. We know CKD is easily defined by the kidney dysfunction lasting for either 3 months or more. And how do we define this kidney dysfunction? Either the GFR is less than 60 and the creatinine is high, or the more important point is if the GFR, the filtration rate, is more than 60, creatinine is normal, but The CKD is there because there is proteinuria, hematuria, or kidney sizes are small. So this definition is important. Two parts are there, with high creatinine or even with a normal creatinine, with a normal GFR. We are all aware of the stages of chronic kidney disease. We classify them based on the GFR from stage 1 to stage 5. The highest one, the good one, is G1, where the GFR is equal to or more than 90. And the last stage is GFR less than 15 when we start thinking about dialysis or transplant. They are further subclassified depending on the albuminuria, A1, A2, A3. So the A1 means if the urine albumin per day is less than 30, A2 is between 30 to 300, and more than 300 is A3. So this is clear. Most of us are now aware of this, and you can see the red zones are the ones where the patient has a low GFR and a very high albuminuria. Fine. So we have understood what is CKD. Now, who are at risk for CKD? Already as alluded to, those with hypertension. 1 in 5 hypertensives has CKD and they don't know about it. 1 in 3 diabetics have CKD. They don't know about it. Those with cardiovascular disease, 3 major risk factors. Not only that, people who are elderly, as we cross 60, 65 years, the kidney function goes down. Those with black race, even South Asians, those with chronic diseases like SLE, HIV, those with family history, those with genetic risk factors, low socioeconomic status, those with environmental exposures. This is becoming very important. CKD of undetermined etiology, maybe because exposure to pesticides, working in hot fields, it's becoming very important cause in our country. Diabetes, hypertension, and this is becoming one of the leading causes. Then prior history of any acute kidney injury, preeclampsia in ladies, they progress to CKD if not monitored, use of nephrotoxic drugs, example, painkillers, and obesity. So remember, in your clinic, do you not see these patients day in and day out? We do see these patients. So remember, any of such patients come to your clinic without any kidney symptoms, still you should screen them for CKD. So what should a physician do when such patients come to him? Let us take a small example. Commonplace case, diabetic, 47 years old, software professional, visits your clinic for the first time. He has diabetic retinopathy, doesn't have any cardiovascular disease presently. He doesn't have any swelling. Urine output is very fine. He is happy. He's a smoker, non-ethanolic, consumes a mixed diet. He has a BMI of 28. Blood pressure is 144/94. HbA1c is 8.3. What will you do? So generally, this is the prescription which is given. Metformin, telmisartan, and glimepiride. So, okay, fine. RAS we have started. We have given anti-hyperglycemic agents, and this is the prescription. So what are we missing here? Is this the adequate prescription? No. What you should do for such a patient, though he does not have any symptoms of kidney disease, you should screen him for kidney disease, because the point is, in stage 1 and stage 2, kidney disease can be completely asymptomatic, no symptoms, urine output is fine, no swelling. You will not suspect unless you test for it. The other important thing is, even in stage 3 and 4, there may be symptoms not related to the kidney. Many of the times patients have chronic anemia, receive blood transfusions. It may be because of kidney disease, because kidney produces blood-forming hormone, erythropoietin. Some people come with bone pains and keep on going around orthopedic clinics. But remember, vitamin D activation occurs in the kidney. That may be a sign of kidney disease. Young hypertensives, 20 years old, they start on medications, BP medications, they continue to take them. In fact, young hypertension is an important sign of kidney disease. Many of them progress to CKD. Those with vomiting, not feeling well, loss of appetite, they get endoscopies done, but never it's correlated with the kidney, because kidney removes toxins. Accumulation of toxins can cause uremia, vomiting, anorexia. So these are very, very important, that the kidney patients can either present with no symptoms at all or with symptoms not related to kidney disease. That's why kidney disease is often missed. Fine. So whenever you have those high-risk group patients who may be completely without symptoms, what are the tools you should use? Should you use a battery of investigations? No. 2 simple tools, that is urine albumin and GFR. Now, urine albumin may not be available at many centers. Many of the government centers do urine protein. That also is okay. Urine protein should be less than 150 milligram per day. But the ideal thing is to do a urine albumin. That's the earliest marker. And urine albumin should be less than 30 milligram per day. You can do 24 hours collection. You can do a spot ratio. If nothing is available in the PHC, even a dipstick for protein is okay. Something is better than nothing. Don't miss it. The other thing is the GFR. Now, GFR, we know that when we were students, GFR used to be very complicated. We have creatinine-based GFR, and the new molecule is cystatin-based GFR. And then we have GFR, which is a combination of creatinine and cystatin-based GFR. So generally, creatinine-based GFR is okay. We use cystatin-based GFR when there is obesity or different in body mass, amputation, bodybuilders, etc. But for practical purposes, creatinine-based GFR is okay unless you are in a doubt. So what we should do not be worried about the GFR. It's very important. All the physicians, whatever be the specialty, should have this online GFR calculator from National Kidney Foundation downloaded on their smartphones. It's very important. It's mandatory. We may be penalized if we don't write the GFR on our prescription. And we use the CKD epi formula most of the times. So you have to just fill the values and you get the GFR. That's it. There is no need for any sort of calculation. But remember, GFR and urine albumin should be mentioned on your prescription. Patient may see you otherwise if you miss to do it. 10 years diabetic and no GFR albumin, it's not good for the patient, neither good for us. So this patient who was asymptomatic had a urine albumin of 640 milligram per day and creatinine was already 1.9 and GFR was 43. He was apparently normal looking, but this was his value. So where do we place him in the staging? He was already in stage 3B-A3. So he was already in the red zone without any symptoms. So what is the next step? What do we do for him? Now we have equations to find out his risk of kidney failure. So this we can do in front of the patient and tell him or her. So this kidney failure risk equation is a new finding. Age, gender, GFR, urine protein. These are the 4 parameters. Plus extended equation has albumin, phosphorus, bicarbonate, and calcium. That's it. So you have to fill these parameters, again, online calculator, and then you get a score. So what was the score for this patient? It showed that at 2 years, this patient who was asymptomatic had a kidney failure risk of 5.65% and at 5 years, 23%. So we had 25% risk at 5 years in a young individual. Is it acceptable? It's not. So he was already at high risk. So what do we do for this patient? What is the evidence-based guideline management? How should we change that prescription, what we saw? First thing is, first point in your prescription should always be about diet. We hear about it, but many times forget to write it on the prescription. So weight control should be advised. Simple formula for weight is, tell the patient, whatever your height in centimeters minus 100 is your ideal body weight. So if my height is 160 centimeters, my weight should be 60 kg. It may not be very accurate, but it is practically useful for the patients. Calculating BMI is fine. You can do it. But for the patient, at least let them have an idea. They come with weights of 95 kg with a height of 170. So this we should tell them that you need to lose so much. Diet, again, we all know vegetables can be given. Fruits can be given in early CKD. Potassium depleted fruits can be given even in late stages. Banana, coconut water, these are generally avoided in late stages of CKD. But in early CKD, vegetables, fruits are fine. Whole grains, we all know, are better. Proteins, plant-based proteins should be given. So we should not tell all patients to restrict protein completely. Animal protein can be avoided, especially mutton can be avoided, red meat, but other dal and all, we should tell all Indians. Indian diet is already depleted in proteins. And CKD patient, we need to take 0.8 gram per kg per day. If we calculate our protein intake, it's hardly around 0.6, a typical vegetarian Indian diet. So there's no need to restrict any sort of dal, legumes, anything for patients. And then again, processed food should not be taken, refined carbohydrates, everything white, maida, rice, white rice, better to avoid. Sweetened beverages should not be taken. So we should tell in a language which the patient understands. And we can still tell them a balanced plate approach, which we advise to non-CKD patients. This works in CKD also. We can tell them your diet can be like a normal person. Doesn't mean you have to stop whatever you like, but we have to give them options. Half plate is uncooked food. 1/4 plate is protein, plant protein preferable, and 1/4 plate is carbs. Indian diet is carbohydrate based. So we have to tell them, don't stop carbs, but reduce the quantity you're taking. We tell them about salt. If hypertensive, half teaspoon salt per day. If non-hypertensive, up to 1. But what we should remember to tell in our Indian patients is that they should avoid hidden salt. Many of them go for rock salt. Rock salt is also salt. It is good, but again, it contains salt. Then when we ask them to take salads, they take a lot of salad dressing. Salad dressing contains salt. That's important. Soya sauce contains salt. Papad pickles contain salt. They restrict the salt, keep on taking papals and pickles. So this also should be avoided. Lemon can be used instead of salt. We should learn to read the food labels. Nowadays, most of the foodstuffs, processed foods have food labels. We should check that. And salt-free spices like black pepper, all those things can be advised. So this is very important. These are the 10 ways to cut down on salt. Many of them go and take Lona salt, low sodium salt. But again, for CKD, Lona salt has a lot of potassium and should be avoided. About fats, you ask them, they tell, Madam, we are taking Saffola. How much? Madam, 5 members in the family, we are taking just 1 tin of 15 liters. That's too much. The oil intake advised is half liter per person per month. Remember, not only the quality, the quantity is also important. So Saffola is fine, rice bran, palm oil, sunflower, these things are okay. We can mix and match the oils. And then again, fish can be taken in non-vegetarians 3 to 4 times a week. So this has to be advised to the patients because most of us take too much of oil in our diet without even realizing it. Next step, what do we tell them? So this also needs to go on our prescription. What we have to tell them is walking active 150 minutes per week. And nowadays, we don't only tell them walk, 3 days walk, cardio. We tell them also about the other exercise, meaning the resistance training, the weight training. So that also, we have to tell them 3 days resistance training. Don't go 2 consecutive days without exercise. We also tell them avoid sitting for more than 30 minutes. So in the middle of this meeting also, we should get up for 5 minutes. Then at least 500 more steps per day, reduce your CV risk by 10%. Very impactful. And also sleep hygiene, at least 6 to 8 hours. All of us are lacking in sleep. We should change ourselves before trying to change our patients. Well, so all this looks silly, but should go on your prescription. Smoking cessation, very important. Moderation of alcohol, very important. So our patient was a smoker, was advised to stop that. Blood pressure control, we know. KDIGO says less than 120, but again, individualized because this was based on the results of SPRINT trial. But again, the major CKD patients were not included there. So consider less intensive therapy if the patient is frail, high risk of fracture. So individualize. 130/80 is generally suitable. But again, you can go for 120 in younger individuals. Which drug we all know, we have heard about it, RAS blockers. So patients, CKD patients, the drug of choice is RAS if they have albuminuria, hypertension, or heart failure. RAS is the go-to drug, the first drug of choice. Now, whether ACE inhibitor or ARB, which RAS, any of them is fine. All the guidelines say either of them. The next important thing is titrate the dose properly. So it doesn't mean we use baby dose. Enam 5 mg, telmisartan 40 mg. It's not going to work as nephroprotective drug. Telmisartan full is 80. Enam is 40 milligram. Inapril is 40 milligram. So these tables are available and we should maximally uptitrate the dose. That's very important. Then till how long we continue, that's a common question asked. So as long as you are able to control the potassium with diet and all that, you can continue. Previously, we used to say till stage 3 up to 30, now till 15. So this is STOP ACE study. In this study, it is said that stage 4 CKD also, if you are able to control the hyperkalemia, it can be continued. So this patient, we have uptitrated. Telmisartan was 40, we made it 80. The other drugs which can be used are calcium channel blockers. You can use the diuretics. Resistant hypertension, if potassium is not a problem, MRAs can be used, minoxidil or hydralazine, and centrally acting alpha blockers. So generally, most of the CKD patients may need a poly pill. So this patient was on RAS blocker, calcium channel blocker, and a diuretic. So the blood pressure was controlled to normal. Now, what about the glycemic control? So targets are 6.5 to 8 HbA1c. Tighter control for younger patients with no comorbidities. Older patients, frail patients, you can loosen the target a bit. But important thing is, as one of the speakers alluded to, it's not about only glycemic control. Your drug should cover everything. Cardiovascular disease should be decreased, heart failure risk should be decreased renal impairment, good patient compliance, prevents weight gain, minimizes risk of hypoglycemia. So we should take all these parameters. We should holistically treat the patient, not only just bring down the sugar. So we know that the first drug generally is metformin, as long as the GFR is more or equal to 30. The dose of metformin beyond GFR of 45 is usual dose, but between 30 to 45 GFR reduced dose. So 500 mg BD would be the reduced dose if the GFR is between 30 to 44. Our patient, we had reduced the dose of metformin. It was 1 gram BD, it was made 500 milligram BD. Now, what about the other drug to choose? So we all know, we have heard of SGLT2 inhibitors. We have so many webinars on this. Why are these renoprotective? We know they bring down the sugar by causing glycosuria, but why renoprotection? Remember that renal damage occurs because of what? By hyperfiltration. And SGLT2 reduce the hyperfiltration. So as you can see, as kidney gets destroyed, the remaining part of kidney starts working more and more, hyperfiltering, and that causes renal damage. In diabetes also, what happens is there is a lot of hyperfiltration. Why does it occur? Because in diabetes, this SGLT2 is upregulated, the pumps which are present in the proximal tubule. So all the sodium and glucose in a diabetic is absorbed in the proximal tubule. So there is very less delivery of the sodium to the distal tubule. So macula densa realizes it's not getting any sodium. So it wants more sodium. It tells the efferent arteriole to do hyperfiltration. More blood comes into the glomerulus, more and more filtration occurs. And this increases the glomerular pressure, increases the filtration, and causes renal damage. Now, what do SGLT2 inhibitors do? Very simple. They block the pumps. So what happens? Sodium and glucose now doesn't get absorbed, goes to the distal tubule. Macula densa says, I'm getting sodium, adequate sodium. So it tells the efferent arteriole to reduce the inflow into the glomerulus. So there is decrease in the intraglomerular pressure, decreased hyperfiltration. And that's the main mechanism of renoprotection. There are other mechanisms as well. So SGLT2 are major renoprotective drugs. They are smart drugs. They reduce the weight, reduce blood pressure, cardioprotective, decrease hyperfiltration. They are smart diuretics, decrease albuminuria, decrease renal work, decrease inflammation. So 8 benefits. So for this individual who was not on SGLT2, dapagliflozin was started. Fine, this was a diabetic patient. For diabetic CKD, remember, GFR more than or equal to 20, you start the SGLT2 inhibitor. Suppose if the patient was non-diabetic CKD, then also we start the SGLT2 inhibitor. So they are useful in diabetic CKD as well as non-diabetic CKD. And EMPA kidney trial has shown one beautiful thing, that even in patients with a GFR between 20 to 45, even if there is no albuminuria, these drugs are useful. Previous all trials showed SGLT2 benefit in albuminuric patients, but this trial, EMPA kidney, has shown even no albuminuria, GFR 20 to 45, it's effective. And this statement, please everybody remember. If you start the SGLT2 inhibitor at a level of GFR around 20, you will delay the dialysis by 2 years. But if you catch the kidney disease early and start SGLT2 at GFR of 85, you can delay dialysis for 26 years, dialysis-free life for 26 years. And this is very, very important. So SGLT2 was started. Still, the patient had albuminuria and he had HbA1c, which was not near target. So what is the next drug to be added in your prescription? GLP-1 receptor agonist. We have FLOW trial. We have so many landmark trials, and this can be added. It can be added or used instead of SGLT2. It can be added to SGLT2 as well. So this patient was started on liraglutide because that was available at that time. Semaglutide is the latest one in FLOW trial, injectable. As of now, it's not available in India. Still after this, the GFR stabilized, UACR still 430. Our target is to bring it to 30. HbA1c is stabilized. So what do we do? What do we add in this patient's prescription? We have added BP medications. We have added diet, exercise, sleep. We have added SGLT2. What else? GLP-1. What else? Remember, the next step is that we have drugs available called Finrenone, which is a non-steroidal MRA with proven kidney and cardiovascular benefit. So if the GFR is more than 25, serum potassium is normal, and still albuminuria is there, despite RAS blockers, despite other drugs, you can add Finrenone. So as of now, we have evidence from Figaro and Fidelio trial for diabetic patients only. And we have FIND CKD trial going on for non-diabetic patients to find out whether Finrenone can be added in non-diabetic patients as well, just like SGLT2. That trial results have to come. So as of now, we add it only in diabetic CKD patients. So what happened to the patient's risk? So you can see that if you add these drugs, what happens is his initial risk was 23% at 5 years, achieving good pressure control. It comes down to 18%. ACE inhibitors, 16%. SGLT2, 12%. And Finrenone, again, 17%. And what is the last statement written? The benefits of this change add over a period of time. And all these actions are synergistic. So you can reduce the progression of renal failure remarkably if you use these drugs. Think, if you were to be the patient, won't you want this prescription to be your prescription where you are on complete standard of care as per the evidence-based guidelines? Definitely, we would want that for us. We should do that for our patient. So this was the complete prescription the patient had. We had started Finrenone at 10 milligram per day because the GFR was less than 60. If GFR is more than 60, Finrenone dose can be 20 milligram per day. Is that prescription complete? Almost. What else needs to be added? Any other therapy? Remember, all diabetic patients with CKD after the age of 18 years, you should add a statin for CV risk reduction. And non-diabetic CKD, any CKD after 50 years, even if the lipids are normal, you should add a statin for CV risk reduction. So many of the times this drug is missing, important drug. Bicarbonate should be added only if the bicarb is less than 18. We need not add sodium bicarbonate to all the patients. Recent guidelines have set target 18. Initially, it was 22. Aspirin, only if the patient has a risk of cardiovascular disease in the past for secondary prevention, not for primary prevention. Our patient did not have a risk. He did not have a CV event, so this was not added. Now, most of the prescriptions contain uricosuric agents. So add them if the patient is symptomatic, has gout, all those things, or if the uric acid is more than 9. If uric acid is borderline 7, 8, you can control with diet. Every time allopurinol or febuxostat may not be needed. If anemia is there, iron, erythropoietin, desidustat, all are available. Desidustat, we can call it something like oral erythropoietin. It's a HIF PHI drug available in Indian market. And if the patient, CKD patient, has mineral bone disease, because if you remember, all these were there in the kidney failure risk equation. So these things also need to be tackled at the level of physician, general practitioner, whosoever is following up the patient. So most of them have hypocalcemia, correct it with calcium. They may have high phosphorus, correct it with diet and phosphate binders. Low vitamin D, correct it with vitamin D. So this, ladies and gentlemen, seems to be a complete prescription: diet and exercise, smoking stop, telmisartan, chlorthalidone, metformin, DAPA, liraglutide, Finrenone, Atorva, and sodium bicarbonate. And what else we can add is a vaccination. So this 10 commandments we should keep in our mind and remember. So ladies and gentlemen, as I said, this is how we diagnose early and treat early to prevent the patient from going into the hands of a nephrologist. So this is our department. This is our dialysis unit. Initially, when it started, we were so very happy. Government gave us 5 machines, then 10 machines, then 15 machines, then 20 machines, and 25 machines, 30 machines. We are running 6 shifts, 5 to 6 shifts. And we have realized that dialysis is not the solution. However number of machines you put, you'll need more and more. 2 lakh every year, you need to dialyze. Those patients are surviving, newer are adding up. Dialysis is not the answer. It can support patients who have already gone into renal failure. The correct answer is prevent progression to dialysis. We have already done a good number of kidney transplants as well. These are our kidney transplant patients. We have done now till date 800 kidney transplants, pediatric, non-pediatric, living, deceased donor, multi-organ, completely free of cost. Our dialysis is free of cost. We were so happy, but now we have realized it's futile. Just treating end-stage kidney disease is futile. It's not going to benefit anyone, not even our country, not the patient. So I strongly say a good doctor does dialysis, a better doctor does transplants even, but the best doctor is the one who prevents the patient's progression to either dialysis or transplant. And that is why the theme of World Kidney Day is very relevant. Screen for early detection. Are your kidneys okay? So we've understood this. Last 2-3 slides, what's the way forward? Make screening available at grassroots level. We are talking in fora, webinar, but the situation is not changing. Why it's not changing? Because if we screen at tertiary care, what's the point? Already the patient is in end stage. What you have to do is start screening at PHC. So the urine dipstick or urine albumin and creatinine GFR should be available there. Any healthcare professional, general practitioner, MBBS, anybody, this should be implemented. The second thing is, I told you about urine albumin and creatinine in India, little bit more screening, check BP, because we are checking hypertensive patients, BP, high blood pressure, high sugar patients who are already diagnosed. What about undiagnosed? We have a lot of pre-hypertension, pre-diabetes. How will you diagnose them? When you are checking their albumin and GFR, also check their blood pressure, also check their blood sugar. So this should be a part of Indian screening tool, and also check their weight. So this is very, very important and very simple and very cheap. Ladies and gentlemen, I would like to draw your attention to this slide. Government is providing free dialysis, largest country in the world, free dialysis districts, 700 districts, dialysis, Ayushman Bharat, transplant free packages we have. Dialysis, remember, cost is 20,000 per month. Government is bearing or the patient. Each hemodialysis is using 250 liters of water in a resource limited, water limited country. And each dialysis is producing 1.2 kg biomedical waste. So each patient generates 144 kg biomedical waste per year. Transplants, we have free packages, but cost of a single transplant, 5 lakh. Lifelong medicines, 10,000 Indian rupees every month, and donors are limited. Do we have screening packages under Ayushman? We have dialysis packages, transplant packages, but what is missing? Screening packages. They need to be included in national and state schemes. This is the way forward. Cost of screening is mere 500 rupees. Cost of early treatment, including the SGLT2 and everything, is 3,000 per month. And quality of life is better. No dialysis, no transplant. The second important way forward is we all talked about the 10 golden rules, but make sure all of them are in your prescription before the patient leaves your clinic. That is what? Audit your prescription yourself. Audit of screening and prescription. Check if you have mentioned UACR and GFR on your prescription. Check if all the golden rules are mentioned on your prescription. So we know everything, but the problem, next step way forward is implementation. We are all working hard. Indian doctors work very hard, but we are working in silos. We are working alone. What we need is teamwork. We need to collaborate. Physicians, general practitioners, endo, nephro, cardio, gynec. Together, we can all make a difference. So I think that was the last slide. And thank you, ladies and gentlemen, for a very patient hearing. And I'll be happy to take if there are any questions.
Thank you, Dr. Manisha, for a very, very motivating and very, very complete talk, I would say, on the occasion of World Kidney Day. You have not only covered the risk factors, you have also tried to cover the basic management of preventing the progression of chronic disease, which is the key for any physician to actually manage a case of CKD. So I think very well done. You have left hardly anything for us to have a panel discussion, but let us have in next half an hour some questions which we can sort of explore more. And I have in my panel, Dr. N.K. Singh is there. I think Dr. Kriplani joined.
Yeah, Dr. Kriplani is held up in a, Dr. Singh, he's held up in another meeting. He told he'll be joining. You can go ahead with Dr. Anupama is there and Dr. Singh is there.
Dr. Anupama, welcome all the panelists. And let's start with risk factors. I think Dr. Anupama, maybe I can ask you first. We should always prefer women first. So Anupama, apart from the traditional risk factors of diabetes and high blood pressure and let's say nephrotoxic agents, we have a host number of, not that traditional risk factors in India, especially in southern part of India, which can contribute to, CKD, especially in younger population. Can you elaborate it a bit more? Dr. Manisha did touch upon them. If you can kindly tell us more about the risk factors, apart from diabetes and high blood pressure. Let me give an example. A young lady comes to me. She's totally asymptomatic. She had pregnancy and her creatinine was found to be 2 or 2.5. She's working in an occupational, in a factory. So just a hypothetical example, Dr. Anupama, please tell us more about the risk factors.
So, especially in the southern part of India, nowadays there is a epidemic of chronic kidney disease of uncertain etiology. A little bit, Dr. Manisha highlighted that. It is among the agriculturists, among the farmers who are working in hot, sunny conditions. We have this raised creatinine and decreased GFR, which is rapidly progressive. So this kind of chronic kidney disease, which is not really related to diabetes or hypertension, that we are seeing in young individuals, especially in the 20s, 30s, 40s, who are actually actively working and they're in the most productive period of their life, working for the family. And so this is one epidemic which is actually baffled many of the researchers in this field. They don't know the exact cause, whether it is related to the environmental factors, whether it's related to the agrochemicals that they're exposed to. So this is one aspect which is probably is an important area of CKD in our country. This is called chronic kidney disease of uncertain etiology, We don't know yet what it is. So these are the two main areas, that is heat stress and agrochemicals, that people are looking at. But also we have a possibility that it could be related to tropical infections like previous past infections, leptospirosis or hantavirus infection, so many other infections which can cause AKI. And that has later on led to the second hit sort of working in the farms could be precipitating.
Absolutely. I think you have hit the nail on this thing. Apart from the environmental factors, and now India has the dubious distinction of being the most polluted country in the world, apart from smaller countries. So, toxins we use a lot, pollutants we are exposed to, and on top of that, there's certain specific infections you mentioned, leptospirosis, malaria, or so many viral infections which can make us prone to develop CKD, which is now labeled, though they are all having what is known as chronic tubular interstitial nephritis, CIN, but now they're clubbed under CKDU. Please understand that this is for the attendees, that we have 1 million nephrons on both the sides, and any episode of AKI, now that's very important, any episode of AKI which we earlier used to consider that it is the patient has fully recovered, would damage some of the nephrons and push the patient into a high risk category for chronic kidney disease. So all these infections can cause reversible AKI or can cause chronic tubular interstitial nephritis, and both can push the patient to a high risk category for CKD. And on top of that, we know studies have shown that those who live in a very high polluted cities have a lower GFR as compared to those who stay in a cleaner country. So definitely our GFR. And on top of that, malnutrition, the birth at birth your GFR may be low because of the low nephron mass, and this could also perpetuate your kidney disease in such patients. So very thank you, Dr. Anupama, for elaborating it.
Dr. NP
Yeah,
Singh.
sir, I'll come to that.
Sir, certainly just for this question, sir, which you told about,
sure.
Really for giving a good inputs on this CKDU, that is chronic CKD of unknown etiology. So I think what I am aware that it is more has been found in Andhra, Odisha and Goa. So the three states. So whether we have seen any region-specific research that identify the risk factors, or we are just speculating about the pollutants and other things, heat?
No, there have been some, very, very innovative ICMR-driven studies where they have done the biopsy also in the earlier stages to find out. And they have also tested the soil, they've tested the environment, pollutions. Clear-cut picture has not emerged. That is why I would always say that it's a combination of various factors. Maybe some of them have low nephron mass, some of them work in agriculture, places where they are exposed to a very high temperature. So heat stress is another important. And then on top of that, atmospheric pollution and nephrotoxic agents, which so commonly we take over the counter. With that, I will ask you, sir, I think your foray is, I understand, more into diabetes. And so first is that, do you feel that we have the same phenotype of diabetic kidney disease in all patients? Or do you think that a diabetic patient, one is that all patients do not develop diabetic kidney disease? So kindly allude to that. Why is it that despite of a poor control, one diabetic does not develop a DKD? On the other hand, despite of a best control, a patient will develop diabetic kidney disease. And what are the various phenotypes of diabetic kidney disease?
Thank you, sir. I think this question is again very important. Let me just tell about something, my own experience, that we see lots of diabetic cases. And these days, definitely, this is really surprising to me again many times, that even some uncontrolled diabetes and controlled hypertension, they are not developing CKD. Sometimes I find. But definitely there are cases which come to us which present with CKD, we detect diabetic, and then we see the risk factors. There are lots of risk factors with hypertension, many the lipids are abnormal, the diet abnormality there. So I think definitely this is very mysterious way sometimes we find. But as far as you are talking about some precision nephrology or precision medicine in diabetes, I think many authors in India also have looked for some genetic markers and some, I think, markers in the urine also. So I think the Arvind Gupta has also done work for that. I think Dr. Manisha has also done many works on that. So I think there are definitely some phenotypes are there. But I don't think in clinically we are going to pick up at present anything like that with genetic markers and with other markers apart from this what we are doing in a routine clinical practice. But this is the I think
Right.
is a very important part, and sometimes also in diabetic. Non-diabetic kidney failures are quite common also. I think not in
Yeah.
all cases we get the same pathophysiology things. So how to
Right, sir.
identify those cases has become a very, I think, challenge to our practice. So I think I would
Right,
like
sir.
to ask you, sir, ki how we are going to
Yeah.
differentiate that
So
and
very good, sir.
that.
Very.
Yes, sir.
So what has happened is, sir, in last 3 decades with the use of ACE inhibitors in ARBs, classical presentation of diabetic kidney disease with proteinuria and gradual worsening of creatinine has evolved, and we see more and more with progressively rising creatinine without preceding a significant proteinuria. That is probably because of the rampant use of ACE inhibitors and ARBs. So we are now getting various phenotypes, and you mentioned very clearly, yes, genetic factors are extremely important. So there are, if you take a family history, there are certain individuals where diabetics runs in families, but diabetic kidney disease also runs in families. So we have to take that history as a very, very important clue. And if a patient has a family member with diabetic kidney disease, is more likely to develop a diabetic kidney disease. What
So,
is more important, which you have mentioned?
yeah, sir. One question that I would like to know here, sir, ki how we are going to differentiate with this CKD and the diabetic kidney disease. I think some questions has also come in the chat box. I think
Yeah,
a
I'll take
definition
them
wise,
later.
yeah, sir. So can
Okay,
I
so let
tell
me,
sir about
yeah,
something
yeah.
about that? Then I take
So
your
let me
inputs.
go back to Manisha.
Yeah.
Manisha, this is a very, very common question of trying to, diabetes is so common. As you mentioned, almost 1/5 of the population has diabetes. And if the patient develops a kidney disease or CKD in diabetes, how would you, as a nephrologist, differentiate diabetic kidney disease, of course, apart from doing a kidney biopsy, from non-diabetic causes of chronic kidney disease? Dr. Manisha, are you there?
Yeah, yes, I'm there. Can you
Yeah.
can you hear me?
Yes, sir.
Yeah, yeah, we can hear you.
Yeah. So, so practically, I mean, there are so many biomarkers, all those things, but practical answer is like diabetic kidney disease is generally it's gradually progressive disease with hypertension and proteinuria. I'll first tell you what was the standard, what we used to understand. And generally, you will have retinopathy, not all the cases, but if retinopathy is there, it's more likely to be diabetic related disease. That's what we used to think. Then there should not be a rapid rise of creatinine, rapidly progressive renal failure. So generally in diabetic kidney disease, the loss of GFR is by 10 mils per minute per 1.73 meters squared per year. So every year the patient loses a GFR of 10 in a diabetic. But suppose you have a fall of GFR within 1 month of 10 or 20, it's definitely not because of diabetic kidney disease. You have to search for something else. So the first thing is presence of if retinopathy, more likely diabetic. Second thing is slower progression, more likely to be diabetic. Now, third important thing is if there is, what do you say, a very short duration, sudden onset, then you may think it might be non-diabetic. Presence of hematuria. If there is microscopic hematuria and all that, then definitely think of something other than diabetes. Now, if a patient with diabetes comes with some kidney disease but has rash all over the body, it's probably not related to diabetes. Think of some vasculitis or some other problem. So these are some broad principles. Then proteinuria, very high nephrotic range proteinuria. There may be an associated glomerular disease also. So these are the conditions where we generally advise a renal biopsy. So that is one of the things.
Manisha has pointed out almost everything, and
Yeah.
the studies have shown that almost 40 to 50% of diabetic patients have a non-diabetic kidney disease.
Absolutely.
Presence of, I'll just repeat for the sake of audience, massive proteinuria, suddenly occurring, presence of active urinary sediment, presence of sudden hypertension, sudden severe hypertension, and as she mentioned, a renal there, which is rapidly progressing, creatinine is rising. Systemic symptoms like rash, joint pains, or other things can, and non, retinopathy, if the patient does not have a retinopathy, it is more likely. And ultimately, these are the patients who end up requiring a kidney biopsy to elucidate on. And let me bring into you, Manisha, just stay there. A very, very common cause of glomerular disease in our country, all over the world, is IgA nephropathy.
Yes.
For a physician, how can we suspect and just elucidate on 4-8 hypothesis? Just for 1 minute, try to explain to them what is IgA nephropathy and how is it that it's so common in our country?
So that's a very, very pertinent question, because nowadays we are realizing that there are some common causes of kidney failure in India. One is diabetes, hypertension. We all know this IgA nephropathy is becoming very, very important, especially in the young people. So when do you think of IgA nephropathy? So generally the patients come with either microscopic hematuria, some proteinuria, and hypertension. Hypertension may be sometimes very difficult to control also. So IgA nephropathy, generally, what we are seeing is those patients presenting with hypertension, some microscopic hematuria, proteinuria in young people. Think that this is not some essential hypertension. These patients definitely warrant a biopsy, because IgA nephropathy, you can pick it up only on renal biopsy. So that's important. Now, why does IgA nephropathy occur? So IgA, we all know, is one of the immunoglobulins. We have 5 immunoglobulins. We have read it in our pathology: A, G, M, E, D. So IgA is because of these IgA immunoglobulin becoming abnormal glycosylation. So what happens is this IgA generally protects the gut and all that. It's there in the Peyer's patches. So any antigen entering from the gut, it incites immune reaction, generation of IgA. The IgA becomes abnormally glycosylated. Then this IgA reacts with antibodies to these IgA, and these antigen antibody complexes get deposited in the kidney. And this deposition leads to a lot of cytokine generation and leak of protein, leak of RBC. And because it's a glomerular disease, hypertension also subsequently follows. So in fact, it's becoming very, very scary the way the IgA numbers are increasing. And the worst thing is, by the time the patient reaches the nephrologist, the damage is already done. They are coming with GFR less than 30, where we can't even give them any sort of treatment. We only end up giving them conservative treatment. It's one of the common causes of end-stage kidney disease in young people. So I
Right.
think awareness about
So-
IgA is very, very important.
So what Manisha has mentioned is what is known as 4-hit hypothesis. You have an abnormal galactose deficient immunoglobulin, which gets aggregated, and then which there is an antibody formed, and then there is an immune complex complement. So what is important is, as of now, in today's 2025, we have various drugs now available. Earlier we were just treating them with maybe steroids and ACE inhibitors in ARVs, but we have a good number of drugs available which can hit them early and which can prevent the progression of that. Brings me to Dr. Anuradha's question next. Is it is very important for us to, as you mentioned, collaborate. The physicians, the family practitioners should collaborate, physician and physician with nephrology. So, Dr. Anuradha, Anupama, sorry, when should we be referring? When should you expect that a physician should refer a case to a nephrologist? Is it when the creatinine is already 6, or you feel that the nephrologist should see a patient at an earlier stage as well because of the various medications which she has mentioned? Doctor, is she there, Dr.
So
Anupama?
yes, yes.
Yeah, yes, ma'am.
So generally, we see that there is a late referral of patients to the nephrologist. Usually, the patients are referred in almost in the stage 5 CKD, when the patient is just about to be dialyzed, or there is no other possibility of improving the kidney function or in such stages, if they refer, the patient is not going to gain much in terms of the progression in terms of the kidney function if the patient is referred late to the nephrologist. So ideally, the patient should be referred early in stage 3 CKD, at least when the creatinine is around 40, 45, 50. Sorry, not creatinine, the GFR is around 40, 45, so that these early interventions for prevention of CKD can be instituted early. That is one. Secondly, they also need lot of improvement in the form of anemia correction. Then the bone disease has to be prevented. The CKD MBD has to be prevented. So all this is ideally done in an earlier stage. Vaccination for CKD also needs to be done in an earlier stage. So, and finally, if the patient is in stage 4 CKD, then they need to be counseled about the type of renal replacement therapy, so they need to be prepared for it. So all this is better done with the nephrologist rather than
Excellent,
physician
Dr.
holding on to the case till the last minute.
Absolutely. And you did touch upon a very, very important aspect, which probably Manisha maybe have skipped, is vaccination. I think this is a forum where we must tell all our physician friends, whenever you see a patient with chronic kidney disease, even with a creatinine of 1.5 or 2, kindly advise them vaccination, not only for COVID, which has now shown how kidneys are affected because of COVID, but also for hepatitis B, for flu vaccination, and for pneumococcal vaccine. So these are the three, and Shingrix has also come. So kindly ensure that every patient of ours, because apart from cardiovascular morbidity and mortality, I think infections are the most important causes of increased morbidity and in fact mortality in such patients. So because of the fact that it is an immunocompromised state, so we should have this forum to educate our physicians that every patient should be vaccinated for hepatitis B. Please understand that the dose is double. Instead of 20, we have to give them 40 micrograms or 3 or even 4 doses. We have to give them yearly flu vaccine. We have to give them pneumococcal vaccine. And we know that two types of vaccines that as of now is available in India, Prevnar and Pneumovac, and we have to separate 8 weeks between the two. Now, having said that, I think I go back to Dr. N.K. Singh again regarding management of diabetic kidney disease. We talked about 4-hit hypothesis in IgA nephropathy, but now we have 4 pillars which are so very important, and all the 4 was referred to by Dr. Manisha. So in your practice, Dr. N.K. Singh, what about ACE inhibitors and ARBs? Now, this is a very, very common question asked to each one of us in all the forums. Now, suppose there are two ways. One is a patient comes to you at the stage 4 CKD, right? Would you like to add ACE inhibitors and ARBs? Second is when the patient is already on ACE inhibitors and ARBs, how long will you continue and what precautions will you advise? Dr. N.K. Singh and the other pillars, just reiterating about that.
I think, sir, just like the 4 pillars in the heart failure, these days we are talking lots and lots about the 4 pillars of the management in this DKD or whatever it may be. So I think apart from the glycemic control, the key drugs, basically I find in my clinical practice that even a patient coming to me showing a nephrologist, and I really sometimes wonder why they have not started SGLT2 inhibitors when it was fully indicated. So I think this is a one drug which Dr. Manisha has beautifully shown how we should proceed. So SGLT2 inhibitors, renally protective, they reduce albuminuria. They even showed that they can halt the dialysis if you initiate in time. So I think the most important part to educate it in that there should not be any fear to start SGLT2 inhibitors when there is clear-cut indications. Although not I'm talking about the primary prevention. Even when you get a case of diabetes with having some albuminuria and other some creatinine rise is there, even in that cases people are not starting. The second thing that after starting SGLT2 inhibitors, he showed also that when we should go for this float trial has come, and then GLP-1 receptor agonist. Now many people are talking about that cost. These are not cost effective, but these are cost effective. And now even this after this we have got EMPA in 19 rupees, even with the great brand from the after this patent is over. And then you have got the GLP-1 receptor agonist like liraglutide is now available in very reasonable price at present. Apart from that, the blood pressure control, ACE inhibitors or ARVs, they also reduce proteinuria and slow progression. This is well known to us. And also, I think beautifully she showed when you should add this MRA. This is a very also important pillar today. A selective non-steroidal MRA that is been renowned that reduce albuminuria and slow CKD progression. And so I think that these, apart from statin, aspirin, lifestyles, I think these drugs are very much essential today to protect the
Yes.
kidney, and this message must be propagated.
So absolutely, sir. And what Dr. Manisha showed you is an ideal prescription containing those 10 medications.
Yeah.
Now the question, let's come to the questions from the chat box. Manisha, now it's very common for, I think, even nephrologists to write something like RenoSave, NephroSave, Renolog, and these drugs are convey some sort of a false sense of security to the patients that my kidneys will be safe. So do you think is there any evidence first? What are the specific type of patients you would like to start Renolog? And let me tell you, I've written an editorial on that. Is NephroSafe really safe? So what should be an ideal dose? So kindly clarify to the audience as to why we should not be using these drugs, and is there any benefit of using these drugs?
So that's a very pertinent question, sir. And I think you can add to whatever I say because you have written an editorial on that. So the guideline says, the new guidelines which have come on the diet say that if you are giving a protein diet of 0.8 gram per kg, there is no need to add all these drugs. Absolutely not
Absolutely.
required. You will be wasting the patient's money. But the guidelines have mentioned the indication where you can use them is, suppose you go for very, very low protein diet, and that is around 0.4 gram per kg per day. So normally we give 0.8, but even that very low protein diet, which practically we are not using, that's the only indication, because with very low protein diet, what happens is that essential amino acids get restricted. So we use these keto analogs of essential amino acids. But again, as I said, those are the exceptions. 0.8 gram per kg is the protein intake we recommend, and these medications do not have practically any role. The other thing is, even if they are indicated and you use them, using minuscule baby doses is of no use. You have to use 1 capsule for every 5 kg. So for a person of 50 kg weight, roughly, you need to give 10 per day. They are very, very costly. So it's better to tell the patient to take a better quality of dietary protein rather than spending and wasting money in these analogs. So that would be my
Absolutely,
on that.
absolutely. In fact, you have already mentioned those 10 drugs which have been shown to be having a strong evidence to prevent progression. So these drugs add to the pill load, add to the cost of the pocket, and also they do not actually benefit. Coming to NephroSafe, actually it contains taurine and acetylcysteine. The dose at which this drug is being given is so low that, and the evidence is absolutely minuscule. So I would suggest not starting. In fact, more important than these drugs is the uric acid lowering drugs, and clearly the mandate is that even unless the uric acid level is very high, more than 9, or if the patient has had an attack of gout, we should not be using febuxostat or allopurinol in such patients because the evidence is not strong. Now, apart from that, then let's come to the next question. The next question is again, I think it's probably important regarding the use of statin in dialysis, though it is a very specific question. Let me answer it before I hand over to others. When you are giving statins before dialysis for cardiovascular protection or secondary cardiovascular effects, then we should continue in the statin. Starting statins first time during dialysis, the evidence is not that strong to say that it protects us from cardiovascular disease. Now, that is my intake, but I'm very sure Manisha and Dr. Anuradha would like to add something on that. It's a very specific question, may not be relevant in today's discussion, but just very short, Dr. Anupama, if you can answer this question.
Sir, as you said, the evidence base for adding statins for the first time in a patient on dialysis is not strong. But for the cardiovascular prevention, And if the patient is already has been started on statins earlier, I think there is no harm in continuing statins in a patient on dialysis. And also for the cardiovascular prevention, I think we can definitely continue
Absolutely.
with statins.
So the evidence is not that strong in terms of starting it first time. But yes, if the patient has had a coronary artery disease and is on statin, we should continue giving these drugs. Now, the next is a very, very relevant and important thing. A physician came to me, and Dr. Manisha did emphasize on the use of calculators. And he was 65-year-old. His creatinine was 1, and he used his calculator, and he said my EGFR is 58 ml. So Dr. Manisha, so what would you convey to him? There was no proteinuria. He was 65 years, and his EGFR is 58 ml. So please, educate the audience regarding the aging phenomena and the GFR with the age.
So I'm glad that question was asked. So the purpose of this EGFR concept is that we should know that even if we look normal, the GFR may be low. But nowadays, what's happening is we have a lot of educated patients, and many of the labs mention the GFR. So it's giving rise to a sort of panic among all the patients, especially the educated patients who come with GFRs of 65, 60, 58. So we need to tell them, see, it means that you have a GFR which is less than optimal, but that only means that you should be under close monitoring. Optimize, follow the 10 rules. If you are a diabetic, control blood sugar, hypertensive, control that, optimize your diet, do exercise, and be on regular monitoring. Regular monitoring doesn't mean every month you get it done. There are guidelines in stage 1, how frequently and all that. So stage 1, once in 6 months to 1 year. 1 year, they say, is fine. In the later stages, once in 3 to 6 months, you get the parameters done. That's it. So the purpose of this EGFR concept is that you tell them, fine, the GFR is not optimal. It's a good thing you did the GFR. Now we know that we have to take care of all the controllable, modifiable risk factors, but don't worry about it. Don't go for painkillers. If you are going for an angiogram, tell your cardiologist that your GFR is this much, even if they don't check it, because then you would be at a heightened risk for contrast nephropathy. So the thing is, knowing about the GFR helps you take the precautions so that you don't end up or progress to end-stage kidney disease.
Absolutely. So what Manisha wants you to understand is that with age, yes, Anupama, I'm coming. With age, the GFR gradually reduces. At the age of 70 years, the GFR, normal person, healthy person will have a GFR of 70 ml only, right? So if at the age of 70, 75, if your GFR is 60 ml, don't worry. What is more important is a marker of kidney damage, and that is, proteinuria. If you have a proteinuria and a low GFR, that is much more dangerous. Anupama, you want to add something?
No, I was about to tell the same thing, that check for proteinuria. If it is not there, then it could be age-related decline in GFR.
Okay. So there are certain more specific questions. Dr. Sangaram, let us know when we have to stop. Otherwise, we'll continue with the question.
Yeah, 8:30 we are closing.
Right, 8:30. Okay.
Yeah.
So then there are talk about phosphate binders. I think again a very, very pertinent question. Now we know that we used to have aluminum hydroxide, then we have calcium based phosphate binders, and now we have these newer phosphate binders. So again, one of you can take up as to the role of phosphorus control in CKD. What is the relevance? What is the evidence? And is there any message to these patients in pre-dialysis CKD, especially? The dialysis patients will invariably follow with a nephrologist, but pre-dialysis CKD, use of phosphate binders with reference to the recent CKD KDOGI guideline. Anupama?
Question, or what should I answer that?
Yeah, Manisha.
Yeah, okay, fine. So that question is also very pertinent. Phosphorus is also called a uremic toxin. Many of the times we forget about it. Why is phosphorus so important? It combines with calcium, and it's one of the major culprits in vascular calcification. We know that many of our CKD patients die because of cardiovascular problems and coronary events, because all the vessels are calcified. In fact, if you take a plain X-ray of many of these patients, you can see the entire vascular tree because you can visualize it. It's all calcified.
Yeah.
So it's important that phosphorus levels should be under control. Now, phosphorus in our diet source is quite high because we take a lot of junk food, the Cokes, even the good food, high protein diet, the good proteins also contain phosphorus. So nowadays, when we prescribe a protein diet, we also talk about good proteins which have a low phosphorus, high protein ratio. For example, egg. Egg has very low phosphorus and high quality protein. So we should choose proteins, plant proteins. Then again, you should go for non-red meat proteins, which contain less phosphorus. That's a major source of phosphorus. Then again, apart from that, items like paneer in your foodstuffs also. The waste items are the Cokes. They contain a lot of phosphorus. Nuts also contain phosphorus. So some amount of phosphorus you are going to ingest
Absolutely.
in your diet. Around 1
So-
gram phosphorus we take daily in our diet. So it's important that you maintain the phosphorus normal. So how do you maintain? By restricting the phosphorus in diet. And apart from that, we have phosphate binders. As Dr. Singh already pointed out, we had aluminum hydroxide, which we are not using anymore. We have calcium-based phosphate binders. So if the patient has low calcium, we go for calcium-based phosphate binders, which are less costly. But you have calcium-free phosphate binders. For example, Sevlamar you have, and lanthanum. Sevlamar is more commonly available. If the patient already has high calcium, Sevlamar is the go-to phosphate binder. Lanthanum is available with difficulty. It's a heavy metal. It's also an effective phosphate binder, but not commonly used in India.
So
We're having, just
Perfect.
last point is about niacin. Niacin is a drug which is also used as phosphate binder, indigenous to India. So Indians have published a lot about niacin, but again, flushing and other side effects are associated with the drug. Dialysis removes only 400 to 500 milligram phosphorus per day. So even in dialysis patients, we end up using phosphate binders. And Dr.
Right.
NP,
So what Manisha has emphasized on the method of reducing phosphate through your diet. Now that is very important in pre-dialysis CKD, which most of the physicians will take. The evidence to reduce the phosphorus in pre-dialysis CKD is, Manisha, not very strong. Though in certain individualized patients we may be able to use it, but what is more important is to to add vitamin D, both in terms of calciferol as well as the active 125 dihydroxycalciferol, because hypocalcemia and hyperphosphatemia would actually drive the PTH, and as you know about all the situation. But yes, definitely phosphate binders are available, both calcium as well as non-calcium based. Now the important question which has come up in the chat box, Dr. Singh, Dr. NK Singh, is regarding the SGLT2 inhibitors. They want to know which is better. There have been trials on Ampared and then the other drugs, dapagliflozin. So various SGLT2 inhibitors are available. My take on that is that any SGLT2 inhibitor you use, there have been trials done at CKD, 20 ml or 25 ml, but all of them are renoprotective. Dr. Singh, Dr. NK Singh, what is your take on that? I think
Kindly unmute.
Sir, both the drugs, EMPA and DAPA, are renoprotective in CKD, but definitely there are some differences in a study outcomes and approvals. So that depends on, like EMPA kidney you see or DAPA kidney, DAPA CKD. So the eGFR in this EMPA trial kidney was 20 to 45, but it was 25 to 75 in that DAPA CKD. So accordingly, there is, even if you see the primary outcome with EMPA kidney, that was 28% risk of CKD progression and CV death. But if you see this DAPA kidney trial, that was 39% risk reduction of CKD and progression. So with that, it appears that one is better than others. But definitely, I think as you told, the both are important. They both have the significant UACR reduction. Both are very beneficial even with if there is heart failure, preserved ejection fraction or reduced ejection fraction with other drugs. So my take away on this topic is that for CKD alone, the both are effective, but the DAPA CKD had a larger relative risk reduction. For CV production, if you go for that, then the EMPA had definitely a stronger evidence for reducing the CV events. For so advanced, if you see advanced CKD, the EMPA can be used, I think, up to the 20 ml per minute, but DAPA is approved for, I think, 25 ml per minute. So the latest ADA guidelines or that taken from your KidGO. So I think that this is the verdict is that the both are good. DAPA may have a slight edge over on DAPA CKD results, but CV reduction definitely EMPA is better. And now today, I think both the drugs are available at a cheaper rate. Even EMPA is
Yes, sir.
available and
Yes, sir.
DAPA. So both any can be used. It depends on
Absolutely.
the trial and other things. So I think the answer is
So,
quite clear.
so absolutely, what is more important to use it in almost all
Exactly.
diabetic patients after metformin, or even sometimes people even prefer it using it before metformin. But in Indian patients, I would first start with metformin, as sir has said, followed by SGLT2 inhibitors, and inevitably all patients should adopt so much of benefit of this drug that we should not bereft any patient of these drugs, which are so important. Of course, then we have other pillars as has been described. Now, just one word about hyperparathyroidism. Someone asked about how to control PTH. Remember, two important causes of secondary hyperparathyroidism in our country are osteomalacia and CKD. And CKD, because of the low calcium, high phosphorus, results in hyperparathyroidism, secondary hyperparathyroidism. By and large, the PTH levels will vary based on what is the level of CKD. But again, specifically, I think we should target improving the calcium and vitamin D levels and also reducing the phosphorus, as has been mentioned. But very rarely, very, very rarely, when the patient develops what is known as tertiary hyperparathyroidism, then sometimes we resort to surgical treatment. There are very specific indications, and also now we have good medical management available, which can also tackle a very high level of PTH. But more importantly, Dr. Manisha, I would like you to tell you the audience just in last, because we are running short of time, regarding the disease donor program. I think we should definitely discuss and create awareness among physicians about why should such a large country, maximum population, but our disease donor program is very, very minuscule as compared to the place where I am sitting. So, Manisha, your message to the physicians and through them to the general population regarding how we can create about this. There now we have a donor card available. You can just with the help of your Aadhaar card, you can register yourself as a donor. And when you tackle a patient who's unfortunately has a brain death, how do you convince your family members to donate kidneys? Manisha?
Yeah, that's a
And
very
I know Hyderabad is one of the leading cities in disease donor program.
Yes, sir. So thank you. That's another pertinent question, sir. So the thing is, first thing is now slowly the disease donor program awareness is going up. India is mainly a living donor program country. 90% of our donations are from live donors. Whereas if you look at Spain and all, they are predominantly going for donations from deceased donors. So deceased donors are again of two types: brain death donors or heart death donors. So you did mention about the donor card. So first thing is awareness. I mean, if celebrities, recently the Indian cricket team was talking about disease donor program. So the awareness is important in the minds of common man because many myths are there. First thing is people think that the body is mutilated and then the body won't go to, the person won't go to heaven because the organs have been removed. It's an incomplete individual. In fact, all the religions support organ donation. Any faith supports organ donation. So this needs to be told. One person can save the lives of 8 people. And what helps generally during counseling is that if we say that the loved one has gone, but if you agree for organ donation, your loved one will continue to live in the bodies of others. So that sometimes really makes a difference. Now, the other thing is about the counseling. So who should do the counseling and how do we identify the donors? So every hospital has these patients. Every day, any big hospital would have some 50 patients who would fit, or 50 or even 100 patients in big ICUs who would fit the criteria of being a brain dead donor. So we should everybody be aware of what is brain dead criteria. So brainstem reflexes we test, they are not there, and then an apnea test. So all these things will be done by the anesthesia team. What is the role of physicians there? Most of the ICUs are manned by the physicians. And we are very proud of our medicine ICU and a neurosurgical ICU because who are the people who identify these patients? We cannot go there because we are the receivers of the organs. So law doesn't permit the nephrologist or urologist or a transplant surgeon to go near the brain dead patient. Whenever you are making rounds in your AMC, just check the coma code, coma score. We all know about the Glasgow coma scale. Anything below 5 out of 15. And if the patient doesn't have any other cause of coma, meaning intoxication, poisoning, alcohol, has a brain injury and is in coma, your responsibility is to just inform the transplant coordinator who should be there at each of the hospitals. It's mandatory now that one transplant coordinator should be there. So just pick up a phone and inform this might be a likely organ donor.
I think
Even the
it is
transplant
so important,
coordinator is
Manisha,
not there.
that
Yes. Yeah. So
we
just
need to sensitize them. We are running short of time. So
absolutely.
just coming back to World Kidney Day.
Yeah, Dr. Singh, before we
Yeah.
conclude, since it is all basically a prevention, without taking Professor Dr. Manish's name in the forum of CKD discussion, since he started enalapril in a small dose for primary prevention, can we take up SGLT2 at the primary health center level to prevent the progression of the chronic kidney disease?
Absolutely. Now the evidence is so strong that two drugs, enalapril or ACE inhibitors, ARBs, and SGLT2 inhibitors, now that Dr. NT Singh has informed us, it is all the patents have gone and the drug is going to be so cheap that it will be available. And I would urge all of us to kindly convince the government to provide these drugs free of cost to the ordinary population, so that these two drugs can very pertinent think. And I would feel that yes, this theme is so important that we should first question ourselves, our family members, and the population regarding are your kidneys okay? I would suggest screening them at the age of 30 years, but specifically those who have a high risk factors like history of diabetes, high blood pressure, stones. We could not talk about kidney stone disease, but which is again a very important contributor to CKD in India. And then we try to test them for any type of albumin, protein, or PCR, or whatever way, and then managing the blood pressure, diabetes. So one sentence message from all the three panelists before I hand over to you, sir. So Anupama, what is message to the audience in today's World Kidney Day, just in one sentence, and then Manisha, and then Dr. N.K. Singh.
My message is please check for serum creatinine and urine analysis in every patient who comes to you. For any particular reason that patient may be coming to you, as you do the sugar tests and as you check the blood pressure and other things, please check also the serum creatinine and urine analysis, which are not at all expensive. We do so many other expensive tests for various other reasons. Please include
Thank
these
you.
two
Dr.
also.
Manisha.
The Kidney Day message: are your kidneys okay for your family, for your patients, for yourself? Simple test, urine and creatinine. That's it. If that is implemented, the purpose is solved.
Dr. N.K. Singh.
My message will be that start SGLT2 inhibitors as early as possible when it is indicated. And also in Indian situation, beware of very herbal nephrotoxicity, common with many Ayurvedic and alternative medicines that take care of the pollutions and also the control infections that can trigger the renal disease. Thank you. Thank you, sir.
Dr. NP Singh, your message until last concluding remarks.
Yeah, I just told that I'm audible.
Absolutely.
Yeah.
So I told that apart from that, my main message is that in the diabetic patients, it's just Dr. Manisha or Dr. Rupma told that you take care of the screening of the kidneys, then control the blood pressure and the glycemic control, and start SGLT2 inhibitors as early as possible when it is indicated. And also many times I find that this herbal preparations, people are coming with CKD, many due to some herbal things. So that said, we also make sort of awareness.
I would like to conclude by saying thanks to.
Yes, sir.
Right.
Yeah. Dr. NP Singh, yeah. So before we conclude,
So
I request
so my connection got broke, and I would take this opportunity to first thank all my panelists, Dr. Manisha, for a wonderful talk and discussing, Dr. Anuradha Anupama and Dr. Singh.
Thank you, sir.
And I would really be, and I'm so happy that you took up this topic and we have been able to
Yeah.
convey this to the larger audience. Thank you very much.
Yeah, thank you, Dr. N.P. Singh. Now I request Dr. Vishwanath to propose the vote of thanks.
Yeah, good evening, all. At the outset, I thank Professor Dr. Manisha Sahai for that excellent lecture, underscoring the importance of prevention. Madam, as you said, how many of our dialysis machines we open or schemes really won't offset the burden we are going to face, and probably prevention is the key. Thank you very much. I think as physicians, we play a vital role in making sure that they don't end up in CKD. I also thank Dr. Narendra Pal Singh, moderator for this session. Always a pleasure to listen to you, sir. Probably he's a great, carrying on the DNP teaching program for such a long time. Thank you. Dr. N.K. Singh, as usual. We all wait to read your comments in CME India. And Dr. Arupama Vijay from our own Shimoga. Thank you very much, madam. I think the panel discussion was also very good. So as usual, Dr. Biradar sir, a galaxy of speakers and a great topic. Thank you once again for this. I thank all the audience also for this. Thank you.
Yeah, thank you one and all. Good night. Good night. Thank you. Happy Holi to one and all.
Yeah, thank you, sir. Thank you.